Okay, hello everybody and welcome to today's HEAL Headliners webinar. My name is Rachel Tillage and I'm going to be helping with the logistical support for this Zoom session. To provide any questions or comments during the talks, please open the Q&A, which you can see located at the bottom of your screen. If you need any technical assistance, please type the issue into the Q&A and one of our techs will respond. And finally, please be aware that today's session is being recorded. Closed captioning is also available by clicking the CC icon at the bottom of your screen. And now I will introduce today's moderator, Dr. Janani Prabhakar. She is a program officer at NIDA's Division of Neuroscience and Behavior. Take it away, Janani.
Thanks so much, Rachel, and hi, everyone. So the Helping to End Addiction Long-Term Initiative, or NIH HEAL initiative, addresses urgent unmet needs around substance use and pain across the lifespan. That includes studies to inform treatment of infants exposed to opioids during pregnancy, prevention studies for teens treated with opioids after routine medical procedures, and effective, safe treatments for adults living with chronic pain. Today's webinar will focus specifically on HEAL research studies in pediatric populations. The Healthy Brain and Child Development Study, or the HBCD study, is the largest long-term study of early brain and child development in the United States. You will hear more about this study from Dr. Berry, and she will share additional insights into her specific role in the study as well. Dr. Kane will share more on data and surgical disparities in the Latinx populations compared to white, non-Latin populations, and how the recent growth of app-based interventions provides opportunities to reduce these disparities. So our first speaker is Dr. Uju Berry. Dr. Uju Berry is a clinical associate professor of child and adolescent psychiatry at the NYU School of Medicine and medical director of the NYC Health and Hospitals Domestic and Gender-Based Violence Mental Health Collaboration. Dr. Berry's work focuses on populations considered high risk from substance use, history of interpersonal violence, and other factors. She co-leads the NYU site of the HBCD study that aims to follow approximately 7,500 children from birth through age 10. Thank you, Dr. Berry, for being here.
Hey, thank you so much for that introduction. So let me go ahead and tell you about the work that we are doing. Oh, did it again. So I'm going to talk to you about the HBCD Healthy Brain and Child Development Study. And as you can hear from the introduction, I'm one of the co-investigators, co-MPIs from NYU that's been invited to be a part of this wonderful national study that will follow children prenatally up to around age 10. But let me give you some background as to why this study is so vitally important. So you see here is a picture of a baby. And when you see a picture of a baby, I often get a smile on my face. And one of the reasons why we get this smile on our face is because we see such inspirational knowledge about what this baby could be. There's infinite potential of who this baby could be and could become. But what if already the environment has influenced a child's path, and especially influenced it in a meaningful way? What are things that occur, signals that occur, could receive during the womb has already impacted and influenced how this baby will develop long term. And what I mean by that concept is actually the DOHAD concept, the developmental oranges of health and disease. There are signals received by the fetus that shape not only cardiovascular and metabolic health in late decades of life, but this theory calls to attention the importance of a prenatal period and shaping risk for emergence of later disease. It appreciates that very early experiences are critically important, potentially scaffolding our overall health, and perhaps there are critical windows of development where environmental factors are particularly impactful. For example, children exposed to adversity, which is one of the areas that I particularly do work in, are increased risk for atypical variations in brain development that in turn are associated with a variety of psychological, behavioral, and physical health sequelae. Adverse environments are ubiquitous, actually, with about 10% of pregnant populations using substances during their pregnancy, and can have long-lasting impact both on socioeconomic development and social-emotional skills. Such other types of adversity that I do study include structural racism and also pandemic-related exposure and malnutrition. One of the benefits that we are trying to understand is how does this DOHAD model represent how we think about networks and network utility, especially around neuroscience. With technology is expanding, we've been able to use these technological advances in fetal MRI. And so we can now ask important questions such as how does environments alter networks? How do alterations in networks even before birth, so in the womb, and you can see here are pictures of a baby in the womb, a fetus in the womb. So how alterations in networks may signal that a child is at enhanced risk for developmental disorder or delay. In order to do this, we are undertaking a huge initiative as a country to understand healthy brain and child development, so the HBCD study. This is a national initiative funded by NIH. And as Janine mentioned, it is the largest study of child development where we'll be following 7,500 children across the country. We'll follow them prenatally, so in the womb, and we'll follow them for up to age 10. This work will help us map multiple aspects of child development from behavior to biome to brain. And of course, we do want to have a particular emphasis on adversity, where we have done really cool statistical weighting, propensity weighting, and oversampling to really understand adversity. So families will be recruited from socially and economically disadvantaged contexts that can face mental health challenges or substance use. But of course, we just don't always want to focus on a negative and the adverse effects. We also really want to understand how policies, because this is a national study, can also promote well-being and resilience. So just again, to reiterate what the scope of the study is, the overarching goal of the HBCD study is to have a comprehensive and high-dimensional data set that facilitates and supports addressing the following objectives. We want to be able to characterize and understand typical neurodevelopment. We also want to assess biological, environmental, epigenetic exposures that affect these trajectories. We also want to assess effects of early life exposure to opioids, marijuana, alcohol, and other substances on neurodevelopment. Identify key developmental windows during which the impact of exposures are particularly impactful, such as COVID-19 or maternal stress. And of course, identify key developmental, assess impact of early caregiving relationships as well. With these linkages that you see here, as well as understanding these causal inferences and correlations, we hope to be able to identify and pick apart what are some of those key methods that really help transcend and understand childhood development. One of the other benefits of this study, which I think is so cool, is its commitment to open science, and that data will be made publicly available to the community. So here is an array of the different domains of assessment. As you can see here, it's a wide range. We'll be looking at EEG assessments, including baseline auditory evoked potentials. We'll also be doing MRI for structural diffusion, resting state connectivity, and spectroscopy. We'll also be doing a lot of biospecimens, research and gathering that for understanding substance use, but also genomic, epigenomic, nutrition, toxins, and COVID-19 related harms, as well as substance and other risk and protective factors. We'll do a lot of behavioral assessments, observational assessments, including the Bailey, and neurocognitive assessments. And of course, wearable biosensors for heart rate, variability, sleep-wake cycles, and physical activity. So as you can see, but the vast domains, it was quite a large study, and really it is to understand all aspects of how we understand child development. This is the first picture of the first 7 years. The first funding period only covers the first 5 years of the study. But here we have outlined the general timeline for the study from enrollment through age 4. Much attention has been paid to limiting participant burden while still aiming to collect sufficient rich information that will allow us to understand their development and healthy outcomes for children. The study participants will have 5 in-person visits and opportunities to provide additional data through remote work as well. We do allow for flexibility across sites, and also, again, really understanding what it means to retain our participants to make sure there's not too much of a burden on them. Here is and as you can see here, here's our main eligibility criteria. We don't have a lot of things that make people uneligible because we want to make it open and really think about external validity as much as possible. So the main criteria is that the person who we recruit has to be pregnant or newly postpartum. We are particularly emphasizing recruiting people during the second trimester of pregnancy. They have to be willing to have a live born child followed in the study for 10 years. So we will be in this family's life for 10 years. And so they have to be willing to be able to come back and work with us through those years. And the parent has to be 18 years of age or older. So again, there's not as much ineligibility criteria. Here are the 25 research sites. So awards were given to 25 sites in September of 2021 to participate in this large study. Many of the sites were picked for their ability to conduct such robust amounts of data gathering, but also recognizing the need to have a mix of racial ethnic variability, urban versus rural, socioeconomic, and substance use risk. The areas highlighted in yellow are here is what I want to point out to you. We do have a very illustrious team of leaders who are helping wrangle all these 25 sites and come up with a coherent narrative. Here we have the administrative core team that's led by Tina Chambers from UCSD, as well as Chuck Nelson from Boston Children's Harvard. The HBCD data coordinating team, sorry, let me go back, I went too fast. HBC Data Coordinating Center is distributed across 3 sites, UCSD with Anders Dale, Washington University in St. Louis with Chris Miser, and the University of Minnesota with Damian Fair. We have learned a lot from the ABCD study, and both Damian and Anders have bring their experience from the ABCD study. Here's an organization chart shown here that follows a similar structure again to the ABCD study. We have formed an observational safety monitoring board and external scientific board as well. Both of these groups are comprised of individuals outside of the consortium to allow us to be able to actually really think thoroughly about the work that we're doing, but also who have relevant subject matter expertise. Since awards were made last fall, the consortium has established a large number of working groups. As you can tell by all the large amount of data that we're gathering, we really wanted this to be a collaborative process across all the different MPIs, across all the sites who do have a wealth of experience. Many of these working groups are focused on distinct aspects of the study. These groups have members from research sites as well as NIH staff. And their charge is to develop a common protocol for study that will be the main activity over the past year. So you have working groups on bioethics and medical oversight. And I'll talk a little bit more about that. We have groups on equity, diversity, and inclusion, including recruitment and retention, and training professional development. And of course, understanding more about communication, and then of course, just specifics around biostats as well. Here's our NYU Langone team, we have 3 MPIs, and we just added an MPI, Dr. Shuffer, who came from Columbia, and 3 co-investigators. I'm going to talk briefly about one of my MPIs, Mariah Thomason, who has done a wonderful work in the work of fetal imaging. Here I'll share a little bit about one of her studies that I think is so powerful and it has really shaped how she thinks about research and research design. While she was in Detroit, she had a longitudinal Detroit-based cohort study that followed nearly 300 families. In this cohort, she was able to do MRI images that occurred at 4 different time points prenatally, so here in the womb, as well as postnatally as well. Amongst the most fundamental discoveries was just understanding that this can be done, that we can actually do images of small little infants as well. And most recently, she had an article come out talk about fetal behavior during MRI changes that has been selected by the senior editors of the Journal of Human Brain Mapping as to be one of the #1 papers of this past year. Now, I work close with Mariah on this HBCD study. She has the expertise in MRI imaging, and what I bring is really understanding how we can work with marginalized populations. The work I do is I work within the city of New York and also within Health and Hospitals, which is the city's largest public hospital system, really to expand services for families, adults, and children who are impacted by domestic violence. We recently just opened and launched 2 new specialized mental health clinics, and we have published several papers on the specialized mental health work that we do within the city. Health and Hospital serves over 1 million New Yorkers a year, and so be able to provide this catch net for all these families who otherwise would not get care is something that's near and dear to my heart. So we do work across agencies to be able to support these families. And this is particularly important because we have to think about the population that we're recruiting. So of course, we have the general population of pregnant women, where around 8% to 10% of pregnant women have used substances, but we are doing enhanced sampling design, where approximately 24%, 25% of the participants recruited will be persons who use substances during pregnancy. This will include opioids, marijuana, alcohol, and tobacco. And then of course, because this is a research study, we need to have a comparison group. So in addition, another 25% of the participants recruited will be persons similar in many ways to those who use substances, but who do not use substances during pregnancy. So what that means is that there'll be a lot of challenges we will encounter, especially to recruit such families and also to retain them. Some of those challenges will be people who are housing insecure or have food insecurity. Of course, IPV, there's a huge correlation between IPV and substance use, as well as trauma history. And one report on parents who've had a 3+ ACEs were 6 times more likely to use substances during pregnancy. There's a lack of reliable access technology. We need to think about legal risks. Again, the idea of using substances during pregnancy, in some states, one needs to automatically call Child Protective Services. And then, of course, lack of reliable access to medical care. One of the challenges and difficulties of this study is that it is entirely observational. So which means that we will not necessarily intervene. There's nothing in the study that allows us to do an intervention. We really just want to observe. But because of these high legal risks and concerns, we do want to make sure that we have robust mechanisms for connecting people to services and be able to provide peer support as well. So we do a lot in thinking about engaging communities in research. This is a paper that I wrote with colleagues to really think about how do we increase diversity, especially in development of cognitive neuroscience, and also increase representation in the research in terms of participants, but also the people doing the work. Many of the things that come out have been thinking really thoroughly about an appropriate research design that involves community partners, using a strength-based framework, so to highlight resiliency rather than deficits, making sure your research staff are from similar backgrounds of the target population. We also want to think about data collection. We want to make sure we reduce barriers to participation, so paying for transportation, accommodation if needed, and really investing time to think about cultural competence and humility. And of course, then there's a third piece, thinking about post-data collection. How do we give back? So we are taking a lot from the community, but we always want to think about how do we give back to the participant community and disseminate that information. One of the other things that we've talked about during our working groups is how do you engage these communities in research? And here's a paper by Flo Hilliard, who's also one of the MPIs in the study, that she was able to interview around 36 pregnant women with lived experience of those who have used substances during pregnancy. And during those qualitative focus groups, one of the main criteria that got people involved in research was having somebody with lived experience work with them and being able to recruit and then retain them. And so we've taken this a big part into the work that we've been doing in terms of making sure that every site who's involved in the HBCD study has a community advisory board. And that community advisory board has several goals and responsibilities. We don't just want it to be, oh, let's just show up and pat ourselves in the back. We really take it seriously, making sure that the community is involved. So we meet quarterly, we talk about recruitment, we talk about engagement, we talk about retention, we talk about legal ethical concerns. Part of our CAB and across many other CABs, there is representative from ACS or Child Protective Services to really think about how we can bring agencies together to really make sure that the study goes on without any concerns. And of course, we have the study navigator. So again, this goes back to that paper that Flo Hilliard reported, that having somebody with lived experience was the #1 reason why families were able to come to research and stay within research. And so each site has been has allocated funds to identify somebody with lived experience or identify somebody who can help those families navigate the research system. In addition, we have incentives for study participation. Each site does a little bit differently, but again, we really want to think about how do you think about recruiting and retaining these families. So we talk about compensation, we talk about transportation, refreshments and dinner. And one of the things that many families have liked has been our donation closet. So we have a huge closet that's full of diapers, clothes, car seat, high chairs, formula, toys. So a family can come in, get their EEG and then go through this donation closet and pick up some clothes. I'm a mom of 3, and I remember my kids just growing so quickly and always having to constantly buy things. And so having somebody donate things can really reduce that burden. And of course, we want to make sure there's swag. So we have HBCD branded onesies, t-shirts, and masks. We do talk about return of results. The other thing is we don't want to be exclusionary, so participation is available both in English and in Spanish. Here are recruitment methods, and again, each site, depending on how they navigate and what the compensation or compilation of their environment is, decides that they want to do it. But usually it's a mix of academic collaborators as well as community-based organizations that work predominantly with pregnant women. We have some community-based organizations that specialize primarily with populations using substances. We do active recruitments. We have RAs that we hire who go to the OB clinic and actually actively recruit in person. And then we also have passive recruitment through flyers or use of electronic health records. We do a lot of community engagement, going to fairs and just highlighting the work that NYU is doing. Social media, having targeted ads, of course, self-referrals and referrals from healthcare providers. So we're creating a robust way of trying to gather people and making sure that it's not just a certain group that we're meeting. And this is especially important when we think about a national study, we want there to be enough external validity to match the general population. I'm going to quickly run through the rest of the slides, but just again, letting you know that we really strongly think about recruitment, but we also really strongly think about retention. This is a retention SOP that one of our working group leaders have put together, Brenda Jones-Harden, who is wonderful in this arena of retention. And so we, in our working group, we talked extensively about what is the HBCD experience? How can we ensure that people who engage with us for 10 years actually like talking to us? And so making sure that, we really are thoughtful in how we think about things, how we talk about things, how we build relationships, how we adapt our own language, how we can be culturally aware of what's happening in somebody's life. We have weekly meetings with our investigators on Fridays, and we are this is a picture of our recruitment and retention dashboard, so we can see how we are meeting our targets. Of course, you can see here, we are at 100%. That is our goal. And so every week we see how we're doing. We also are able to understand demographics and making sure, again, that we're recruiting enough Spanish speaking or Latinx or people who are using substances. And then, of course, because we are doing research and clinical work, there are going to be some concerns of clinical alerts. And so we have a system in place to be able to alert the clinical clinicians to be able to identify if there are any concerns that need to be acted on. So I'll end here with just, here's our website, the landing page of our website. Please check it out. Please let people know we are actively recruiting. Please let them know to join. And here are pictures of our flyers. We have launched and we anticipate the first data release to happen next year, spring of next year. So stay tuned. as we share some of our findings from then. But I'll end here and thank you for letting me talk to you about this wonderful study.
Thank you so much, Dr. Berry, for that wonderful presentation. And we'll now move on to our next speaker, Dr. Zeev Kane. So Dr. Zeev Kane is a distinguished professor at UC Irvine. Dr. Kane is also executive director for UC Irvine's Center on Stress and Health, where he leads a team of researchers investigating multidisciplinary approaches to managing pain and anxiety in children undergoing surgery, emergency care treatment, cancer treatment, and who have asthma. Dr. Kane's commitment to improving surgical experiences for children and their families makes him a leader in pediatric anesthesia and perioperative medicine. So thank you, Dr. Zeev Kane. I'll hand it over to you.
Thank you so much, and congratulations, Uju, for such a impressive and large study. I'm talking to you today from Southern California, and it is beautiful here today. We're going to start with our presentation. I am part of the Center on Stress and Health. It's a center that includes investigators from UCI, CHOC, and Chapman. We are using interdisciplinary biopsychosocial methodologies to look at the experience of children undergoing medical interventions and conditions, with particular emphasis on healthcare disparities. It runs throughout our entire programs. Today, I'm going to talk to you about, in particular, about the perioperative settings. Although our centers ranges from oncology to the emergency department to the settings of asthma and other diseases. About 10 million kids undergo surgery every year. So it is a significant number. And based on our studies for the past 30 years, I can tell you that about 60% of these kids exhibit extreme anxiety and distress during the procedure. Beside the obvious reasons why kids should not have anxiety and distress, we should note that extreme anxiety is associated with increased analgesic requirements, longer lengths of stay, maladaptive behavioral changes, and in fact, increased pain, acute pain, is associated with chronic pain syndromes of all kinds. Now, there have been interventions in the past for this, and in particular, hospital-based preparation programs, and of course, giving the kids drugs. The challenge is at least twofold. First, for those of you who are not aware, surgery in the US is moving more and more to the outpatient settings. And just to give you an example, from the adult population, 80% of all hip replacement today are done outpatients. So 80% of all the kids now have outpatient surgery. The kids show up in the morning, have surgery, go home in the afternoon. So it's a real issue to actually educate the kids and the parents. The second is, we don't want to give too much drugs, and we're all aware of the opioid epidemics and the opioid pandemics. So anything that we can do to not use getaway drugs is a good purpose. Now, in parallel to the changes to outpatient surgery, we have moved into the world where everybody's connected via the internet. Pew Research shows that, in fact, up to 90% of all underrepresented populations are in fact using internet. So they give us a particular opportunity to basically change from a world where we bring the patients in or giving them drugs to a world where we can use web-based interventions to actually prepare these kids and manage their kids' pain before and after surgery. Our journey in this did not start yesterday. In fact, these are two articles that we published at 2015 that document the development of a web-based, which is different than mobile. I'll talk to you in a second about that. And in fact, a preliminary randomized control trial. Anybody who wants more information, please refer to those articles, and we're also here. Now, when we talk about an intervention, there are essentially three kinds of interventions, behavioral interventions. There are generic interventions, there are personalized interventions, and there are tailored interventions. Everybody understands intuitively what the difference between them is. Of course, tailored interventions are much better. And in fact, if you are focusing on tailored intervention, their structure is simple. You have an intake part, a matrix, and an output part. So let's talk now about our specific case. The output part is provision of information, coping styles, coping skills enhancement, and modeling. The target is pain and anxiety. Now, what's the intake for this particular case? Well, the intake is anything, any variable that will affect the effectiveness of the output or the efficacy of the output on the target that you want. Example, if you talk about provision of information, that's obviously affected by the coping style of an individual, right? And so the intake part in our interventions has a child component and a parent component, and we have elements in it such as coping style, trait anxiety, temperament, and so on. It also has some more basic things such as, well, what kind of surgery is the patient going to have? Different surgeries have different elements in them and need different information. So that was the initial conceptual framework, which again is very different than more conceptual framework of web-based interventions or apps, which are very generic. And on the left-hand side, you see some pictures from the original web-based intervention. And on the right-hand side, you essentially think some of the information that we are providing to those patients. Now, about 5 years ago, we moved from a web-based intervention to a mobile health app, which needed a tremendous amount of work and efforts, but we have accomplished that with a previous R01. And part of that R01 was to migrate it to an app. And the second part was to do a effectiveness trial, which included about 670 children in 2 sites, Seattle Children's Hospital and Chalk UCI. And in this effectiveness trial, we have shown, among other things, that the intervention is effective in reducing pain in children. And you can see 2 data points here. Again, this is from over 600 kids. This is the home phase scales with a cutoff of 3 in kids aged 2 to 7 who undergo outpatient surgery. And as you can see, the pain of the probability of developing pain is much lower in the group that did receive the intervention versus a group that did not receive the intervention. For those of you who are wondering, so WebTips is the intervention group, WebInfo is the attention control group, and I'll get to that in a second, because obviously you can't really do a trial like this without a very appropriate attention control group, which essentially means a whole other app that's devoted to the attention control. And in fact, on the right-hand side, you can see the parental report on child's parents. So that's nice. In fact, it's more than nice. It's an intervention that is effective and is being disseminated to hospitals around the country. But during the trial, we in fact noticed that patients of Latinx origin are in fact less responsive to this intervention, even when they speak English. And obviously we have a huge population that doesn't speak English altogether. In fact, you are aware of the statistics that 25% of all the kids in our country are in fact Latinx. And so we need to take care of them. Surgical disparities in children and adults within the context of minorities is very well established. There was a call of the NIH in 2016. The American College of Surgery has called for it. We're working on it. I would love to see that the areas move faster than where it is. It's mostly right now in the area of descriptive studies, but we are moving forward. Now, data from our center and other has essentially showed that these kids, the Latinx population, suffers higher levels of anxiety and higher levels of pain after surgery as compared to control groups that are made of white children. So obviously that's a problem. And so while we developed a beautiful intervention for the general population, we needed something for this particular population. Now, when you take an intervention that's used in a general population and try and apply it to a particular subpopulation, such as Latinx children, you have three options essentially, right? You have an option of basically just translate the intervention and that's it. You have an option of starting from scratch and do a tailored intervention, which is exceedingly expensive. You have a third option, which was first described by Bernal about 20 years ago, which is to take the intervention that exists and do a cultural adaptation to it. And so cultural adaptation, and you can see the definition in particular on the third point here, it's basically a systematic modification of an intervention within the context of a new language, a new culture, new values, and new beliefs of this population. It is not simply translation. I can't overemphasize that. And we have first described it in this article. Again, you have access to it, that talks about the concept and the construct of this. Obviously, this has never been done in the surgical settings. And so from that perspective, it's highly innovative. Now, how do you start this? Well, Barrera about 10 years ago came up with an overview process. We have taken that overview process and modified it to the case of mobile health interventions, which have obviously their own needs. But obviously the first step of all of this is to, in fact, bring all the stakeholders to one room. And we have a group that calls the Madres, and these are mothers of children of Latinx who underwent surgery. They have viewed the intervention. They do speak English, and they said, that's beautiful, but we need to really modify this. And then you bring in, you basically do a mini CBPR. We bring in all the stakeholders. They look at all the elements, and they decide if they first are adopting or adapting. Adopting means we're just changing it to Spanish, or adopting means we really have to change it. When you move then to step 3, you have to look at what elements you need to actually adapt and how are you going to change it. And obviously, once you have done that, you need to move on to evaluation, to integration, to modification of the original, beta testing, refinement, and then an efficacy trial. This is an example of some things that we have used. So for example, you look at appearances of characters. Well, in the original interventions, one of the figures was redheaded. We needed to change essentially all the figures to be culturally appropriate. And you would not believe it, but it's actually not easy to get culturally appropriate pictures to make sure that we display what we want to display. The content, stories, and role of characters. Another example, in the Latinx culture, the role of the grandmother is very, very important. Well, guess what? In the original web tips, we did not have a grandmother. We now have a grandmother. You are looking at the value and importance of family. There are a number of cultural values such as familisma and simpatia. And what does that mean? Obviously, the Latinx population relies on the family, on the core family and the extended family, much more than the general population. Well, we need to acknowledge it and include it. This population also does not like confrontation with healthcare providers. They like to get along. That's the simpatia. So please don't expect from this population to ask questions at the end when you're done with your speech as the provider. You really need to engage them. And so we needed to train the parents about that. And of course, they're highly or more involved in spirituality and religion than the general population. We have to integrate that. These are just 3 examples. So your next question may be, that's very nice in conceptual framework, but how do you actually do it? So here's an example. Here is religiosity. So in the intake part, when we integrated it, we actually ask questions to the parent in the intake part of the intervention of the app. How important religiosity is for them. And then based on that, they get a score. And based on that score, the matrix then assign them in the output if they get how much information they get, how much coping style they get, and so on. The same goes for sympathia. So each output is essentially tailored based on the input of the patients. Now, I'm going to show you a couple of slides, and then we'll actually look at the website of the application. The intervention has a child parent, children aged 2 to 7, and an adult component, a child component and an adult component, 2 different elements. It provides information provision, coping style or coping skills enhancement, and modeling. This is just a screenshot. And the first question is, well, are you a boy or a girl? And so the features that are shown throughout the app are different based on if you are a boy or girl. Here is the grandmother, which we indicated to you, for example, it was not before. The characters themselves were changed to make sure they're culturally appropriate. And then at the bottom, you see a picture, and again, culturally appropriate. One of the first steps they do, and this is all from the intake part, which I will not show you on the app because it's long, it's 5 minutes, and we just don't have that amount of time. But this is simply asking them, tell me where your pain is. Because on the output part, we actually have analgesic medication recommendations, and that's based on the surgery that they have. So there's a process there in which we ask them for that information. And then this is a screenshot of the spirituality, and you can see how does that look. Now, one of the challenges of mobile health interventions is that it's very hard to create an attention control group. So what we have done is we essentially created another app, which is called LWeb Info. And that app has in it provision of information and is it modeling, but it does not have any coping styles and is not tailored. But it is an app like the other app, and it has videos in it just like the other. And we actually have done multiple days of efforts and weeks actually to make sure that they are comparable. And you can see at the table of how the apps are comparable. It has a very high score on the credibility scales. So we consider it as a major part of our intervention, or our trial, I should say. Now, let's switch on to the website. And so remember, there is an app as well, but I can't show you the app, obviously. So this is the website. This is the adult side. And in the adult side, you can see that you have things before, during, and after surgery. This is during the surgery part. And during the surgery part, you have presentations, and you go from one part to the next part to the next part. In all these presentations, there is the 3 elements that we talked about. There is a navigator here. Now, the app was translated. When it was translated, it was for a 4th grade level. There is an element here. If you can't read, the element will actually, this will actually talk to you to make sure that we are going through this. And we're very careful to make sure that all the kids are embedded in this. And I wanted to show you, well, let's move on to the kids side because we don't have a lot of time. So this is on the kids side. So this is how it starts.
Dr. Kane, I think you need to switch
Hola.
your screens because we can't see your video.
Robot. Número de modelo 01.
Ah.
Mis amigos me llaman Billy. Billy Bot.
Okay, I was told you can't see my videos. So I'm going to stop the share and share again. You should be able,
Yes, we see it now.
you see it now. Okay.
Estoy aquí para ayudarte con tu visita al hospital. Escuché que vas a tener un procedimiento. Bueno, entonces, esto es lo que debemos hacer. Siendo el modelo más avanzado de la serie WT, bueno, soy como el único modelo. Soy la primera versión.
So I think you're getting the idea. And then we have a 360 visit, 360 degrees visit in the particular hospital that you're using. This is, for example, the ORs in the room, and the parent can simply, highlight a specific area. And when they highlight the specific area, they will actually see information on it. For the kids, we then have games that they actually
Hola, soy Ana.
can play with. And finally, they have activities of all kind. This essentially downloads an activity to make sure that the kids are playing with it. So lots of information, lots of ideas. Now, let's talk about the particular application. It's an R61, R33. And so within the R61, so far we completed the development of the intervention, the culturally adapted intervention. We did beta testing, and we are now in the middle of the preliminary randomized control trial. Conceptual framework, and I am almost done for those of you who are worried about timing here. Here is the intervention. It has elements in it that has shown in the past on multiple studies we have done to reduce preoperative anxiety, which obviously, again, studies we have done reduces emergence delirium and post-op pain, which then triggers a decreased pain at home, decreased maladaptive behaviors, better rate of return to routine function. That's on the child side. On the parent side, we have decreased preoperative anxiety and increased parent satisfaction. So this is the conceptual framework and the analysis that will be done later on. Where are we today? Well, we are right now at the preliminary randomized control trial, which is right here. And with our amazing team, we have recruited to date a total of, I should know this, Heidi, recruited today a total of about 63 subjects. So we're doing exceedingly well. In fact, we are doing better than our milestones. And then once we're going to finish with that, we're going to make sure that everything looks good. Then we're going to move into an effectiveness trial, which is the R33 part, for those of you who are not familiar with this model. And that will include 670 kids from Seattle Children's Hospital and from us. So we are about 1.5 years into a 5-year process. With that, I'm going to stop. I'm happy to answer any questions. I am sorry you had a glitch with not seeing some of the website, but hopefully you had a good time.
Wonderful. Thank you so much, Dr. Kane, for your great presentation. And we'll move on to the Q&A. And Dr. Berry, if you would like to put your camera on, and I'll just begin and going through some of the questions that we've received, and we'll try to get to as many as we can. So this question is for Dr. Berry. One huge challenge with large studies such as this, such as HBCD, is ensuring sufficient representation of ethnically diverse populations, especially since it involves genetic testing and genetic markers from ethnically diverse populations, which lends to enhanced generalizability of the results. So the question is, what measures are you putting in place to ensure this, so ensuring sufficient representation?
Yeah, no, that's a great question. And, one of the things that I was so excited about when I signed on to be a part of the study was to actually figure out how do you answer that question and how do you do it effectively. And especially for communities where they are marginalized and are not necessarily involved in these research studies. So there's two parts to how I would answer it. The first part is that we have a really thoughtful statistician and statistical team that has been able to think about representation across each different of the 25 different sites. So prior to us recruiting, each site was given a list of demographics targets that we should meet in terms of race, ethnicity, and language spoken, employment status, income level. And that was supposed to be how we would think about recruitment and where we would think about. So for New York, since we do have a high Latinx population, around a quarter of our population or a third of our population will have to be Latinx. So that's the first part, that each site was given a particular parameter specific to their site in terms of how they can recruit demographically. The second part is that we have a tracking monitor that each site can use to determine when people are being recruited, are we meeting those target demographics? And if not, then we can go back and try to, again, target certain populations that we are lower on. And so there's a live opportunity for us to track and make sure that we are being thoughtful about how representation matters.
Thank you. Thank you so much. I have a similar question for Dr. Kane, but kind of in a slightly different perspective. So it was really great to see some of the great tools you have for adapting the platform to different cultural contexts. And I'm wondering about that bidirectional relationship with communities that are coming from different cultural contexts. So there's a generation of culturally appropriate tools and measures that you described, but I'm wondering about the adoption of these instruments within the community and how you engage communities in a way that they see value in their participation in the study or value to them.
Yeah, thank you. Very early on, we established an advisory committee of the Madres, and we really don't do anything without them. They are part of the NIH proposal. In fact, they are listed as co-investigators, or at least advisors to the application itself. And so they are telling us exactly how we should engage with the population and helping us with the process of engaging the population. And so it's a bit easier from the perspective of we're dealing with children who are coming to have surgery. And so when, or I should say days before they actually come to have the surgery, we engage them and we show them the benefits of the platform and the benefits for the kids who will undergo surgery. And the adoption rate is literally 95% from that perspective. Now, we do have our own challenges, which actually are less than I expected, which is the availability of things like iPads or phones. So within the grant, we have it available, which means that if a family comes to have surgery or we contact them, remember the intervention is 5 days before surgery and 10 days after surgery, right? They get it 5 days before surgery. They're being trained on it 5 days before surgery. They have it during the holding area, and then they have it for 10 days after they finish surgery. So they need an iPad, or they need an iPhone, or they need an Android or something. And so if they don't have it, we give it to them. That's how we assure that they're actually part of the intervention. So we have less of that issue simply because these are kids that come to have surgery, but we don't really need to go out to the community and address that.
Great, thank you. And so keeping on time, I think we have time for a few more questions, but there is a question that I think is appropriate for both of you, which is challenges to recruitment and retention. And I guess specifically for HBCD, the second part of that question says this differ across study sites, but maybe both of you can talk a little bit about, the greatest challenges, to recruitment and retention, and we can start with Dr. Berry.
Yeah, no, I mean, again, a lot of the work that we do and especially for sites, is about recruitment and then retention, because the whole purpose of this cohort study is that you want to be able to get people into the study. And then in order to study it longitudinally, you need to have those same people stay in the study. And so the study would not even work or be even it would be kind of futile if we weren't able to be thoughtful about how we thought about that. And of course, there are multiple different challenges. One of the challenges that I alluded to is also thinking about doing a study like this of the scope across different states, across 25 different states, and making sure that we have a standard protocol, but also building in some flexibility because each state and composition is really different. For example, some policies may be different in one state versus another. Again, whether or not you have an automatic call to Child Protective Services, if there are substance using or not. And recognizing if that's the case, how do you not alienate families by putting them at risk for being introduced to more systems in their lives? And so each working group really is thoughtful about that. We have working groups on ethics to think how we can avoid that or make some changes for site-specific sites. Of course, I mentioned a few things about how we want to think about retention, having community advisory board, and also, having people with lived experience. The other thing too is that we have a lot of young research assistants who do most of the research we're doing. And we try to be, again, I use the word thoughtful, but I do like that word. We use the word thoughtful to be cognizant of the fact that we want people to look like the community. Again, though, but there is a difference in terms of years. Research assistants are just right out of college. And so, training them to think about cultural humility and how do you engage families who are in a different part and different stage in their life. And then just having what we like to think about as light touches, not being too heavy-handed. I can attest this. If somebody keeps calling me multiple times and calling me, I'm probably going to not want to engage with them. But how do you have light touches to be able to, say, hey, I'm still here, I'm thinking about you, and just checking in. So case in point, we have mothers who we recruit who are in their second or third trimester of pregnancy, and then we reach out to them again right before pregnancy, right before the delivery of the birth, just to say how things are going, and then we'll send them a gift in the mail. It's always nice to get a little gift in the mail to say, hey, here's a onesie. And I think that's just a nice way of just, letting people feel like we are family, because at the end of 10 years, you probably will become family at some point. And we want them to feel very comfortable with our presence.
Obviously, there are differences between a gigantic cohort study and an intervention study. And when we do this intervention, remember, we've done this before with the different population across sites. You have to remember that this is done within clinical settings. This is not about the patients comes to have some examination. This is about the patients who are coming to have surgery either here or another location. So the protocols have to be adjusted to make sure you're not in the way of the clinicians, because otherwise they won't let you do the study. And so we are making sure that from a feasibility perspective, we adjust it. From the family perspective, obviously compensation always helps. And it always helps when they believe in the intervention. Yes, our research assistants are fantastic. We also use methodologies like texting. In fact, the intervention itself has a texting feature built into it. It's automatic, and we actually ask them, I think, twice or three times a day, what's their level of pain? And if their level of pain is above 3, we actually get a notification, and we have somebody reaches out to them to manage their pain beyond the instructions in the intervention itself. So they are motivated because the intervention is actually helping them individually beyond the concept of collecting data for science. And so our attrition rate is relatively lower. That said, attrition rates are always an issue. And we are doing everything we can to make sure we don't really have a large proportion of that.
Absolutely. Thank you so much. And I think we have to end it there. We're just coming upon the hour, but just want to thank you both. Thank both Dr. Kane and Dr. Berry for their time and their presentations. And I will hand it over to, I guess, Rachel to stand up.
Thank you to everybody who attended today and to our wonderful speakers. We really appreciate it. And I just want to say that today is our last HEAL Headliners webinar for the year. So hopefully we'll see you again at a HEAL event next year. Hope everybody has a great weekend. Thank you.